Hello. If you're watching this, do you like this? Do share it and do put comments in all the way through. So I'm Trish Murray from the Birth and Baby Academy. I'm currently coming to you from Edinburgh in Scotland, and tonight we are talking all about birth and consent and why consent is so important. At the end of this, please go to the birthandbabyacademy.com and download 101 questions about birth. It's more like about 180, but that will really help to support you to have a much better birth experience. So I really wanted to talk about consent, and that came up from a conversation last week that I had with somebody who was watching this, and it was all around, did she have a right not to ask for a vaginal exam? And could she say no? And it really started to bring up questions in terms of in terms of when can you say yes and when can you say no to the different questions that you're asked. And I really want to do this so it helps you to understand what your choices are and how to make the right choices for you, but also very much about empowering or enabling you to say no at times, and understanding why we don't want to be making lots of decisions through the birth process. So I've got my notes here because it's quite an in-depth topic, and so I really wanted to make sure that that when I was giving you information, that you had the right, access to absolutely the right information and the right words. So first of all, when do you need to consent? So during birth and during pregnancy and birth, in labour and birth, there's so many times that you need to give your consent. So these are things like every time you enter the hospital, you're consenting to going to that appointment. That is actually, that's consent. Vaginal exams at any point, including a membrane sweep, you need to consent to that. When you're in labour, quite often there's a procedure called the stretch and sweep. Again, that's something you need to consent to. Any monitoring, including mum or baby's heart rate, is you need to consent to that. And also any testing or anything in your pregnancy, you're consenting to all of that. So that's all consent. Continuous fetal monitoring, again, you're consenting to that. Pain relief, so whether that's epidurals, morphine, gas and air, all these various things, you're consenting to that. Induction, consenting to that process, that procedure. Episiotomy, having forceps or ventouse. Managed third stage of your placenta, so that's when they give you an injection to help your placenta come out. Cesarean births, newborn observations, giving your baby vitamin K, suggestions to feed baby alternatives to breast milk, students undertaking interventions, people arriving in rooms. So that was something that recently happened to me. I was at a birth and 8 people came in to do a ward round, which is ridiculous. And then afterwards, things like exposing to, or touching the patient afterwards, specifically touching the woman afterwards, specifically her breasts or intimately down below, really without actually checking in first with her. Particularly when they, if you've had a baby and they want you to express colostrum, they're in at you quite quickly, so that's another time. And before speaking to a patient about any medical matters in front of other people, these are all times that they should be giving consent. And the reason I really wanted to bring this up, because I wanted to start to turn a lot of it around on its head. So we often think that when we go and see the different healthcare professionals, so it could be your midwife, your doctor, the obstetrician, whoever it is, that you are asking for permission for something to happen, like so that you can get permission to have a caesarean, that you can have permission to give birth vaginally, that you can ask for permission to use the birth centre or have a home birth. But actually, it's the other way around, actually. They need to ask permission for you to go into the hospital to have a vaginal birth. They need to ask permission from you to go in and have a caesarean. We need to start flipping it around in its head. Now, obviously there's times when it might be medically reasonable to do that, so I'm not for a moment saying it's not, but equally it's always our right. Now, what is consent? So I wanted to I printed off the Royal College of Obstetricians guide about consent and obtaining consent. And it said to obtain informed consent, the process of shared understanding, which is really important, and decision making between patient and clinician must be approached diligently and robustly. Okay, so there's some quite sort of key words in there. So specifically about it's like a shared understanding, and it's a decision-making process, and robustly, which is the third thing I want to finish off. Because often what happens with these appointments, people go and see the see the consultants or go and see the midwife, but it's never really a shared understanding. So I had a client recently, and she was having to go in for growth scans, and I was saying to her, but why are you having to go in for growth scans? Why do you have to go in every 2 weeks? And she was saying, I don't know. And then she'd experienced severe birth trauma, and she'd said, so that was the reason why she was having, being told that she had to go in, and she was told that she was high risk, and all these things. But yeah, she didn't really have an understanding why she was going in and why she was high risk and what all the issues are. So there was absolutely no shared understanding there at all. And actually it really puts her on the back foot in terms of making decisions. And I will talk through this about different people that I've worked with in terms of really helping them to gain proper informed consent. So just going back to this, before seeking a woman's consent for a test, treatment, intervention, or operation, you should ensure that she is fully informed, understands the nature of the condition for which has been proposed, its prognosis, likely consequences, and the risks of receiving no treatment, as well as any reasonable or accepted alternative treatments. Uncertainties that the woman may have about the management of the condition should be discussed. And I think that's really vital, because often with these meetings, things aren't always discussed. It's very much that you go and see the consultant and they're telling you that they want you to do X, Y and Z and what they will or they won't allow you to do. So again, another meeting I was at recently regarding a VBAC, and the consultant was saying to my client, was saying things like, we won't allow you to go beyond 10 days. No, we won't allow you not to have continuous fetal monitoring. No, we won't allow you to, we won't allow you to, go in the water, whatever it was. Very sort of things like we won't allow you to, whereas actually these were all the things that she had every decision to do. And again, that should be flipped on its head. It's not really about what they won't allow her to do, it's what she will allow them to do to her. And I really want to get that across quite clearly. If you've just joined, don't forget, this is Facebook Live, so do like, comment and share that you are on this, and don't forget to leave comments after the Facebook Live so that and I will reply to them over time. Okay, so I think I've touched in terms of like some of the vocabulary used, and some of the vocabulary used is very, very negative. And there's a thing that we sort of call, coercion, and that is basically when a woman coercion is when basically a woman is really convinced about a decision through fear, not really through information. So she's coerced into making decisions. So going back to that feedback client, what they were saying to her is that 10 days after your due date, you're putting your baby at a high risk. And so that's the way that they're coercing her to go forward to go in for a repeat cesarean. And that was exactly what happened to me 6.5 years ago. That exact coercion happened to me. So they were saying to me, well, we won't allow you to go 10 days beyond your due date. So if you get to that sort of stage, then we want you to come in for a cesarean because you're putting your baby at risk. So immediately you think, oh my God, something terrible is going to happen, I must go in. But one of the things we as women can do is we can say, well, actually, really, can you tell me what the risks are? And when you start to ask that and you start to ask them for the evidence around the risks, actually what you probably generally find is that you get given very, very, very little evidence. And what they say to you is our guidelines say X, Y and Z, but actually looking at the evidence behind those guidelines, quite often it's quite sketchy, and the consultants themselves aren't very sure of really that research behind the guidelines. They just know that that's what their guidelines are, and they're sticking to those because that's their protocol and that's what they want you to do, because you know it fits in with their system and their insurance models and all the things that they're worried about. So, but we'll go back onto VBACs in a minute. So other times might be, so I want to talk about vocabulary again and coercion. So other times might be around vaginal exams. So I work a lot with clients around vaginal exams and what the pluses and minuses are of vaginal exams. So vaginal exams are used to assess the progress of labour, and it's something that they've used historically for a long time, but the evidence around vaginal exams in terms of their accuracy and also in terms of them being an indicator of how far along in labour you actually are quite limited. So so when if we're using that as a way to assess how far a woman is in labour, actually it's not really a great indicator of that at all. But what happens often is that when you go into labour, you go into triage, and they will ask you if they can do a vaginal exam to assess how far progressed you are. And one of the things around that is because they don't want you to use up empty beds. So they don't want you to go, it's a way for them to manage and I can understand that, it's like a hospital policy, it's a way for them to manage the number of people that they're looking after at that time, and they don't want people to block beds for a day when they can have somebody else or two people in and out on that bed. So it is that way. So they want to assess you to see how far you are. But rather than looking at the women and saying to the women, do you know what, I don't even necessarily think you're far enough ahead by looking at her and assessing her, they do this vaginal exam, and they say, well, we won't admit you until we've done this vaginal exam. Well, actually, that is coercion. Like, that is absolute coercion in terms of we won't admit you until you until you've had this vaginal exam. So that's the sort of thing that we're sort of talking about, and that happens a lot. But there's other times, and they don't necessarily ask you for your consent, they're just basically telling you that you're not allowed in until you've had this vaginal exam. But it also happens other times as well. So it can be that sometimes when they're into a vaginal exam, they can do this thing called the stretch and sweep. And it's happened to a client of mine. So basically they did a stretch and sweep, no consent at all asked for. They didn't say to you, look, you're only 2 centimetres. What I would suggest that we do is that we try and stretch the cervix to see whether we can get labour to advance a bit more quickly. There's no asking at all. It's a very, very, very painful procedure, and they just went ahead and just did it and said, oh look, I've tried to help you along, and probably in all given the benefit of the doubt, it's to really support the women, but actually sometimes it might be better asking before they actually start heading off to do that. And then obviously with that whole thing to do with vaginal exams, I quite often will counsel clients before that and explain to them like what's going to happen, and they will and sometimes actually it's the clients that ask for it, but that's completely different. And I had a client back a few months ago, and she was hilarious because she was like, I don't want vaginal exams, and as soon as she gets into hospital she asked for vaginal exams, and all the way through, because she wanted to know how far she was, whether it was worth keeping going. And I have that quite a lot as well. And then at one point they were saying, we want to bake your membranes, and yet she was like, no. And it's just really funny. So what was great about that birth was that she had complete and utter choice in terms of what was happening all the way through. So I think that's what I really like, is when clients feel like that they can make the right choices for them. I just want to go back to some examples. I had a client I worked with a wee while ago who was going through VBAC, and I've already explained a bit about VBAC, and I wanted to read out an email to you just to just to help you to understand actually what sometimes can happen. So I got this email, and just sometimes what can happen and the things that are going on behind it. So I got this email and it said, you know, please, I need to vent somewhere. So I've been really irritable the last couple of days and sat and thought about what was bothering me. And it's the consultant appointment we have at 40 days, 5 days after my due date. The consultant pushed for it as she will be, and it's in exclamation marks, it's in speech marks, she will be getting tetchy about me if I've not delivered by then, and wants to move on the elective section plan. I agreed to it to keep her quiet, but it's really playing on my mind now. I will only be 5 days over at that stage, and if the baby isn't here, I fear putting a date in the diary will mess with my mindset, and I'll almost surrender to a section, and my mind won't allow my body to go into labour itself, no matter how much I want it. Am I being careless or stupid in cancelling that appointment closer to the time? It's not even with the doctor, as she's on holiday, so I don't even know who I'm facing that day. So with that, that's really quite a typical scenario. So basically what happens is when a woman who's going for vaginal birth after cesarean, she gets to 5 days after her due date, they're really keen that she goes in so they can put a plan in place. And that was what happened. That's what happened to me, and very much why I became a doula and really started to push around informed consent and women's rights, because when I started to realise what had happened to me and that I didn't need to have a repeat cesarean 10 days afterwards, I got really, really upset about it, because I'd really planned to have this vaginal birth, and I think I'd always felt this birth experience had been ripped away from me. But I think what's really key here is there's a few things there. Did she have to go to the appointment? No, she absolutely did not, because we're opting into those appointments, so you don't ever have to go to the appointment. Now, sometimes you might choose to go to those appointments, and I'm not here giving medical advice. I'm saying if you're feeling harassed and you don't necessarily want to go to appointment because you feel that sort of fear that it's not the right thing for you, that your intuition is telling you it's not the right thing for you, you do not need to do that. It's absolutely always your choice in terms of what you do. And then the thing was, it really was about that mindset, where she didn't really want to have that cesarean booked in. She wasn't against having a cesarean if she needed to have a cesarean, but she just felt it wasn't giving her body enough of an opportunity to do that. And this is something that comes up again and again and again. A client recently, and this client a couple of years ago, it comes up again and again and again. This discussion, especially around vaginal birth after cesareans. You know, this do I have to go, do I have to put, you know, do I have to book in the cesarean, do I have to, you know, and it's that pressure that the staff, that coercion. And with this client as well, they kept repeating the risks again and again and again. And that is actually against the professional guidelines of the Royal College of Obstetricians and Gynaecologists, is that they don't necessarily need to keep repeating those risks again and again. If you've just joined this Facebook Live, please do feel free to ask questions of me. I love getting asked questions, and do press on the like or the heart button, whatever it is. And don't forget that at the end of this, you can go to the birthandbabyacademy.com and download 101 questions about birth, which will really help to prepare you all the way along. So anyways, I've got my notes here because I did want to have a kind of plan what I was talking about. So the other time that consent really comes along often is around the time of induction. And what happens during the time of induction, so women get to their due date, and then when they get to due date, they automatically get given a day, 10 days after their due date, which becomes their date for induction. And again, I think we need to change the terminology around that. So they're booked in for their induction, but they're not offered, and you know, really what they should be saying to these women is, I'm offering you an induction 10 days after your due date. But actually that doesn't really happen. Actually, they're just given this date, and then women immediately think, well, actually I need to go to that because I've been given this date, there must be a reason for it, and they don't really question it. Now obviously some women might be getting really fed up with been pregnant and really had enough, and actually 10 days after their due date they really want to go in and they want to give birth. They've had enough of being pregnant or whatever it is. But actually the evidence around post-term pregnancy is really, really, really sketchy, and we don't necessarily always know if that's the right thing to do. We do know that the risk of stillbirth does go up slightly. It does go up slightly, and I'm not saying it doesn't, because that would be lying, but we don't really know why that happens. So, and I wanted to point out, one of my sort of things I always wonder about is it because we interfere so much with that process after 1 to 2 weeks that maybe we're making it worse? Maybe we're doing something. I don't really know, because what we do know is actually a lot of the things that have happened around, there was around negative outcomes around birth have often been down to human error. And I do wonder if, after that sort of 4 to 2 week time, because all these women are getting induced, whether that is part of the issue. I don't really know. I don't think anybody really knows, because there's so little research and evidence around that time. But I just think it's to sort of question it. And I also think it's really up to women to make the individual choices that are right for them. For some women, they don't necessarily want to go down that induction route, and they need to make the right choices for them, and they can always say no whenever they want to. So, one of the things is around sort of whose risk is it anyway. So, what I find is that the women who come to speak to me are often really sort of highly intelligent women. Most often than not, it's for their second pregnancy. So the first pregnancy, they've just gone along with the system, whatever's happened with the system, and they've gone on, and they've either been induced or gone into labour, and something's happened. So they come to see me for their second pregnancy and birth because they want to make it 100 times better. So they want to make it so much better. And with that, the women that generally I work with are generally highly intelligent women. They've generally got really good careers. Some of them have got PhDs. Like, they've got these really, really amazing sort of jobs. And they've spent ages really unpicking what happened in the first time round, and second time round they want to make all their own choices and all their own decisions around their birth, which is brilliant. And these women are highly intelligent, and they go off to meetings with different healthcare professionals, and they are told that whatever's happening, that they are putting the baby at risk for wanting to delay a caesarean or not go through induction or whatever it is. And as though something terrible is going to happen to them or their baby. And these women are made to feel about this big in these meetings. They are really spoken. I mean, I've sat in them, I've been there. They're really, and I'm made to feel this big too. Who's this doula that's turned up, and so we're all made to feel like this big in these meetings. And actually, I think that that's so wrong. And actually, it goes really against the Royal College of Obstetricians and Gynecologists guidelines around consent, because it should be a shared understanding. I'll get back to you in 2 seconds. It should be like a shared understanding rather than it should be a shared understanding rather than just them telling you something. So I do think that is absolutely absolutely vital. And I don't really, in terms of, it's in the best interest of the mum that her and her baby are well at the end of it, rather than anybody else. So if that mum didn't think that risk was was so tiny that it was worth taking, then it's up to her to take that risk. Anyway, sorry, Louise. Hi, Trish. Just wondering about monitoring during labour and the benefits and drawbacks of this, particularly at home when you want to be alone with your partner or not to focus on medicalisation of normal birth. Well, that's quite a hard question. So it's totally up to you, and I think it's really worth researching yourself. So the benefits of monitoring would be that you know that you and your baby are well. So when they come in, they will monitor your blood pressure and your baby's heart rate, and if the baby's heart rate starts to go up, it's like an indicator that the baby's in distress. So they will want you to go in. So it's totally up to you, and I've worked with clients who have wanted absolutely no monitoring whatsoever, for whatever reason. But I do think it's worth just getting that check-in, double check the baby's fine. The disadvantage of that is that when we're in that primal, we want to get into that primal state around birth. So we want to get to the sort of stage where people aren't interrupting us, people aren't talking to us, things aren't going on, that we can just go into ourselves and we don't have to think externally. Then when we're in that primal phase, then people coming in and touching us, monitoring us, that will start to get our anxiety going and start to get us to think, oh, is everything okay, baby? Is everything okay with me? And it's very hard to shut that down when you're in that birthing phase. So so that would be the disadvantage of it. So it's totally up to you. Does that make sense, Louise? Does that help you? Has that answered your question? So the plus is the fact that you know everything's fine, and if baby's in distress, that you will know that there's an issue. And the minus is just that having that person in your space is difficult. So, and that's one of the things with continuous monitoring, is when you're in the hospital and you're getting continuous monitoring, they put those monitors actually on your belly, and those things move all the time. So what ends up happening is either you end up having to lie on your back so they can hold it in place, or else when you're standing up, somebody's holding it in place as well. So somebody's constantly in your space. That's the thing with continuous fetal monitoring, and plus everybody's constantly checking all the sort of charts. So that's a really good question about monitoring. So it's totally up to you. I mean, I did have a client recently who totally didn't want any monitoring whatsoever, but that was her choice. I don't offer advice. It's always up to people what they want to do. And that was absolutely her choice. She didn't want to be stressed out. She felt really stressed out anyway. So anyway, on one of the chills I wanted to give you was about BRAINS. So BRAINS is like a really good acronym to use when you want to make your own decisions around it. So BRAINS is the benefits, the risks, what are the alternatives, what is my instinct saying, can I do nothing, and what's the science behind the decision. And that's a really, really good tool to use in your to weigh up all the pros and cons. And if you're not happy with what the healthcare professionals are saying to you, you can go through that. At the second birth I went to, I was so cross because I hadn't taken pen and paper, and actually now I take pen and paper because we sit down and we map it all out and we have to sort of think about it. So what I would say is that trying to make decisions in your labour is really challenging, and that's where your birth partner comes in. And it's absolutely vital they're aware of all the things that you've been reading and what all your wants and desires are. Because if you start getting asked in your labour to make decisions, then you are stopping that primal brain coming in, and you're in the thinking brain. And once you get into the thinking brain, your labour will slow down. So you really want your partner to be helping to do all that processing of information. So it's really vital that they are fully on board. So anyway, that's the end. That's half an hour. That went so quickly tonight, so I could go on and on and on. So that's a half an hour up. So I just want to say thank you and for joining, and do keep adding comments to this, and also if there's things that people would like to have on the Facebook Live, then I'm really happy to do special sessions. So please just do ask. And I think that's it. So thank you very much. Don't forget to go to the birthandbabyacademy.com and download 101 questions about birth, and we'll see you there. Okay, take care. Bye.